Welcome, everybody. I'm Dr. Jason Terk. I'm a pediatrician from Keller, Texas, and currently serving as chair of the Texas Public Health Coalition. I'm really delighted to see so many faces here in the audience who are interested in protecting and improving public health in our state. I'd like to thank each and every one of you for coming. We're also live streaming this event on Facebook Live, and we welcome everyone who is joining us virtually. Special thanks to the members of the Texas Public Health Coalition and the Texas Medical Association for their generous support of this event. Before we get to the official program here, I would like to acknowledge the presence of elected officials here in our presence. First of all, Representative Donna Howard. We thank her so much for her service over the years. And Representative Vicki Goodwin, we so appreciate your service as well. Thank you. And as a special surprise, we have with us Senator Eddie Lucio, and we so appreciate your service as well. Thank you. So I'll continue with your introduction. I think we already know quite a lot about you, John, but nevertheless, we're going to make sure that everybody hears the full Monty. We had the opportunity to hear directly from the leader of our state's public health agency, Dr. John Hellerstadt. We asked for his perspective on how public health in Texas fared through the pandemic and what he sees on our horizon. John Hellerstedt began his career as a pediatrician, like me, but not at the Austin Regional Clinic. He started practicing at Austin Regional Clinic, and after 18 years in 2000, he entered public service as the medical director of the Bureau of Medicaid Managed Care and the Children's Health Insurance Program here in Texas. And then it was at that time called the Texas Department of Health, and then of the Medicaid CHIP Division, then finally the Texas Health and Human Services Commission. In 2007, he accepted a position at Dell Medical Children's Hospital and the Seton Family of Hospitals. And in 2016, he returned to state service as the Commissioner of Texas Department of State Health Services. Under his leadership of the agency strove to achieve a healthy Texas and fulfill his mission of improving the health, safety, and well-being of Texans through good stewardship of public resources and a focus on core public health functions. Everyone, please join me in welcoming our State Health Commissioner, Dr. John Hellerstedt.
Thank you, Dr. Turk. I really appreciate that. Got my presentation up there, and I'll go through some slides. Everybody always wants facts and data, so we'll start with some of that. So, obviously, the big story over the last 2.5 years has been COVID-19, and I will tell you right up front that my theme for this is that public health, Texas, and our society as a whole really weathered the storm very well. I'm not a veteran, I've never been in combat, but I do think the analogies to fighting the pandemic as a form of warfare are fair, because it was a matter of life and death, sacrifice, struggle, cost, anxiety. And I think one of my also biggest themes is where we find ourselves today, where our society is intact, and we are ready to go forward from this and prosper. That outcome was by no means preordained. If we had not been able to, if you will, thread the needle and make our way through to this point, it could have been a genuine catastrophe. Instead, it was just a big disaster. So I'm going to give you a snapshot, talk about where the trends are, talk a little bit about our resources and that sort of thing. Here's our case counts. Keep in mind, this is really just the number of people who went and got tested. Particularly at this point in the pandemic, where there's so much home testing going on, just take those numbers, if you will, as kind of a barometer, but not necessarily a fine point on it. Our current hospitalizations are 3,400 or so. It's been at that level, 34, 35, 36, up and down for many weeks now. And one of the reasons that the hospitals, is really two reasons the hospitalization number is extremely important. Number one, inpatient hospital capacity is not infinitely scalable. You can't just make up all the inpatient hospital rooms that you have. So there was always a danger at the very beginning that somehow the rate at which people got sick and needed hospital care due to COVID would overwhelm our ability to provide that care. And of course, throughout the pandemic, we had several waves, several peaks, if you will, surges. And we, at one point, had about 14,000 extra staff that the state managed to help recruit and hire and come to the state of Texas to be nurses, respiratory therapists, pharmacists, to fill in for those hospitals and generate that capacity and really give some relief to the regular staff, many of whom, of course, were also sick with COVID. So that hospitalization, we did not want to run out of hospital space, because if we had, that would have breached, I think, one of the deepest, if somehow tacit, parts of the social contract that we have in society. If suddenly not only people who were sick with COVID couldn't get in, but women who were in labor, 5-year-olds who needed their appendix out, people who had strokes and heart attacks and those sorts of things, cancer chemotherapy, that would have really undermined public trust in the fabric of society itself, and that is a serious, serious thing to contemplate. The other thing that's important about hospitalization is, of the things that we can measure, it's one of only two that has the entire population of the state of Texas as the denominator. One is hospitalizations, and the other is deaths. And of course, deaths is a lagging indicator. So going back to the testing, well, testing's great, but it's always a sample of the entire population. It's never the entire population as a whole. Here you see 87,982 fatalities. That's quite remarkable. That's just in the state of Texas. That exceeds the, prior to COVID, that exceeds the highest national total for fatalities due to influenza, for example. So when people, early on, I haven't heard it much anymore, would say, oh, COVID's no more dangerous than the flu. Yes, it is. It's many times more dangerous. It's 10 times more dangerous. So as far as our trends, again, we've seen it come in waves. Right now, we're sort of off of the last really high peak, which was the first part of Omicron. Now we're into the Omicron variants, and we're just really doing a slow churn through the population. We're getting lots of people getting infected, including myself. Double boosted, got COVID, came down with it, and I'm not careless out there. That just shows you the other thing that has happened throughout the pandemic, and will also dictate the future, really, of what happens with this virus, is the nature of the biology of the virus itself. So the original virus was about as contagious as the flu. The current variants are about as contagious as measles and mumps, which are among the most contagious diseases we have. In addition, the sneaky virus has found ways to reinfect people who had been infected with previous versions of the virus, and also to evade the immunity that comes from the current vaccines, although there's potentially some relief on the way. The good news, in a sense, out of all of that is that the predominant variant that we have today is the BA.5. If you get BA.5 and recover from it, you are solidly immune to BA.5. So it's not like that's necessarily going to be a never-ending cycle. But keep in mind, viruses don't want to kill you. Viruses want to reproduce. And that is exactly the trend that we've seen in the variants that we have. They're more capable of causing infection, but they're less susceptible to making people seriously ill, needing the hospital, or dying. Here's the graphs. I think in many ways they speak for themselves. Notice how high, this is cases in this slide. Notice how high it is with Omicron. Well, that again is because we had so much more testing available and so many more people went and availed themselves for testing. When we look at the next slide, which is hospitalizations, you can see that the peaks are really rather comparable to each other in terms of the ability of the infection to put people in the hospital. And here we are at fatalities, again, a lagging indicator. Typically somebody might get infected. It might be a week or so before they get sick enough to need the hospital. And once they're in the hospital, they're given really highly supportive care. And typically, again, if they have a fatal outcome, it's because they've gone to the intensive care unit and received very intensive care. So the deaths always lag the cases and even the hospitalizations themselves. So pandemic response, I'll kind of let you read the slide itself. This response piece of it is the thing that I'm most proud of, and it's also the thing that I think most people outside of actually the agency in doing public health, and so I would include in that, in Texas we're a home rule state, so wherever a city or county has a health department, they answer to their mayors and county judges respectively. But we work with them in close function. But throughout the pandemic, we've all ended up having to do the same things. So it's not really about the science. It's about society. The science part of it is simple. The science of how to prevent the spread of a respiratory disease has been known for 100 years. Physically staying away from people, doing things like wearing masks, sanitation, other types of personal practices. They absolutely work. There's no doubt about it. People who wonder, well, none of that really worked. Why, if that didn't work, why did we have some of the lowest influenza seasons that we've ever had during the pandemic? It was because enough people were practicing those, what we call non-pharmaceutical interventions, the masks, the distancing, and that sort of thing. Enough people were practicing those things enough of the time that it interfered with the transmission of influenza as well. Proof positive. But what was really challenging for us was the logistics of all of this. So if you remember early on, we learned a lot about this. Early on, the CDC was saying, well, you're not contagious unless you're symptomatic. Well, that was based on their best guess of the behavior of earlier coronaviruses. Now we know that 80% of the transmission was probably from people with minimal to no symptoms. Amazing. Early on, what would have been nice was for everybody to have a really highly efficient mask. But guess what? Just as the need for personal protective equipment, especially PPE, and especially the high-grade professional levels of PPE that you need to keep hospital personnel and healthcare personnel safe, the demand for that went through the roof and the supply dropped to zero. So we were in a tough bind at that point, and you can repeat that over and over again with things like therapeutics, with things like vaccine. One of the very best things, and I should keep moving, otherwise I'll never get through my slides. One of the best things about our vaccine response was we had formed the expert vaccine evaluation panel in Texas. So it was a 17-member group, people who developed vaccines, previous commissioners, academics, virologists, but really, I think the key to its success was having 4 senior members of the Texas legislature participate. And boy, did they participate. They were there working the whole time. And what it did was it gave them insight into the fact that there's a lot to know, there's a lot of data, there's a lot of interpretation that needs to go into it, a lot of science, but in the end, you're talking about making policy judgments about what is the best way to serve people. And of course, early on, we had very little vaccine, and we had very, very high demand for vaccine, and we did come up with our prioritized populations, which were actually slightly different than what the CDC did at first, and what other states did. Guess what happened, though? Many states then changed and followed what Texas did, where the primary populations were people who worked in hospitals, and then the elderly and the infirm. Why people who work in hospitals and not some other type of profession? Because uniquely, in a hospital setting, during that period of time, if you went to work, there was a 100% chance you were exposed to COVID. You can't say that about any other professional situation. And so part of my background as a physician administrator made me also realize the hospital is a team. It is a tightly knit team. It's not just doctors and not even just nurses. It's pharmacists, it's chaplains, it's the food service, it's the housekeeping service. You have to keep all of those people healthy, as healthy as possible and as protected as possible, so they have the confidence to come to work and they continue to serve all of us. So getting the vaccine out and allocated was quite a challenge, but I didn't feel like there was really any real sense that people kept trying to jump the line and get ahead of the priority populations that we had. Did it happen here and there? Yeah, probably, but at a certain point, hey, don't waste any vaccine. The vaccines were technically difficult to handle. And so if you open the vial, a multi-dose vial, the very best thing you could do is actually give the whole vial to somebody, to anybody who might qualify for it. Then we went into the therapeutics, the monoclonal antibodies. Now we have oral therapeutics. This, again, was also a very complex logistical operation because these things were in high demand. And of course now the one monoclonal antibody that still is effective against Omicron B5, or in the Omicron variants, the bebtelovimab, the federal government will stop being responsible for the purchase and distribution as of August, this August. I think they had said August 15th. There might actually be a few tranches left after that. I'm going to skip over here a little bit about this. What's the best thing? You know, so one of the first bullet point here is about communication. Let me go back to having a bigger picture of the entire pandemic, if you will. Going back to, again, saying it's not about science, it's about society. And society is about leadership. And leadership in this situation was about effective crisis communication. And there's actually a little course you can take online from the CDC on crisis communication. It's 3 hours long. It's done by the CDC and could be 30 minutes long and do the same thing. But there are 3 principles of crisis communication if you want to be the authority. And of course, as government, we want to be the authority. So you have to be first, you have to be truthful, and you have to give people something to do to protect themselves. I personally, and this is self-serving in a way, I'm sure, I personally think we did a pretty damn good job of that here in Texas. Back in the day when there were news conferences, I was here, the governor was there. I hope it was very clear to all, because this was the truth. I was providing advice, he was making policy, he was making decisions. That is precisely the right combination, because policies are always about compromise. Policies are always about weighing risks and benefits of actions. And also the policies in our society are about the consent of the governed, if you will. You can't be a leader if you don't have followers. So you have to be able to do things that people trust, and you're going to have to enact the things that people are going to do. Because if they don't do them, there's no point in having some pie-in-the-sky sensibility out there. Again, I'll let you kind of read the slides yourself about the best practices. I hope, Karen, we can make these available to anybody who wants them for reference. Here's my other big theme, what I call blind sight. We're all familiar with 20/20 hindsight. If we all had 20/20 hindsight about the pandemic, I'd be thrilled. That means you really looked in the past and you saw accurately what happened and why it happened, and you learn the right lesson from it, and you know what to do going forward. I fear that I hear a lot of, not always, but I hear a lot of blind sight, where people in essence are saying, look, it all turned out okay. Why did you make us do all of these things? Why, you governmental, overlord? Like I say, the victory that we enjoy today, and there's really no other substitute for that word in my opinion, the victory that we enjoy today was by no means foreordained. It could have turned out much worse, very badly. And the fact that we are where we are today is a tribute to the fact that enough people did enough of the right things, enough of the time, that we really kind of went through it. Back to each of those peaks that we saw in terms of hospitalization, those all came this close to us completely running out of the ability to take care of people. And there were sections of the state, regions of the state, where things got really, really tight. And if you needed certain types of surgery, you couldn't have it done in that local region. You had to be transferred out. Fortunately, there was less of that here than there was in some other places, but like I say, we came this close. So avoiding this blind sight, I think, is one of the most important things that there is going forward. And part of it, to me, the main thing, you know, at one point in the pandemic, they were saying, well, you know, people aren't listening to politicians. They don't believe them. They don't believe elected officials on this sort of thing. That's really a sad state of affairs. I don't think it had to be that way. But it really ultimately is, and again, this is the awe in which I hold our system after working in the government now for 14 years or so. It's like Churchill said, democracy is the worst form of government except for all the others. And it's absolutely true. And so we did it our way. We did it the American way. We did it the Texas way. It wasn't the perfect way, necessarily, in the viewpoint of people on kind of either end of the spectrum, but it worked, and it got us through to where we are. And we should take stock of that and say to ourselves, we do have what it takes to face a crisis. So again, the blind side, I won't really overburden it, but again, in conclusion, thank you for having me here. And the last thing I would sort of close with, people often ask me, well, what should we do to prepare for the next pandemic? Well, I'll tell you what we should do. We should prevent the next pandemic. We should figure out ways to monitor for emerging pathogens and be able to suppress them before they get to a pandemic level. A pandemic means that all of your defenses have been overwhelmed. And if you get to a pandemic situation, again, it's going to not be about the science, it's going to be about society. And if you have a pandemic, that means society is in crisis. And that's the thing you want to avoid. So thank you all very much.
Thank you so much, John. We were able to solicit some questions prior to this Distinguished Speaker Series talk today, and I'm happy to be able to have some time to go through some of those questions. But before I do that, I'd just like to underscore one of the things that John said in his presentation, which is the nature of blind sight. I think it's the nature of public health that nobody's going to notice when you hit the bullseye. Okay? If you're too aggressive, people are going to complain about the oppressive nature of public health interventions. And if you're not aggressive enough, then you have excess morbidity and mortality. Nobody's going to notice when you have perfectly balanced those things. And so I think that's really an important point to be made. So I think that we have a lot to be proud of, as Dr. Hellerstedt mentioned, about how we responded in Texas to the pandemic. But there are always opportunities and lessons to be learned. And I guess the first question I would ask of you, John, is what lessons can we learn from our experience from this pandemic as we potentially face future pandemics, and how can we prepare better for them?
Well, thank you. Again, I hope that we would see, step back and look at, if you will, the global cost of this pandemic. I mean, it's got to be multiple trillions of dollars, not to mention the morbidity, the lost lives, the disability that's going to be there because of long COVID. I hope we would look at that cost and say, you know what? If we invested a mere fraction of that in the ability to detect and provide surveillance and provide countermeasures to emerging pathogens, we will prevent the emergence of another worldwide pandemic. That's going to be something that will take a lot of wisdom on the part of decision makers in order to do, because the price tag for doing it will look big, but again, look at how much we've had to pay, if you will, the cost we've had to pay because of this pandemic, number one. Number two, I think I would really like to see the next time that at the national level, the kind of paradigm that I was talking about plays out better. And what am I saying? In other words, there should be one spokesperson, if you will, for the public health science piece of it. And standing right next to that person at the national level should be the President of the United States. And they should be on the same page. It should be clear that one is advising, the other is making policy decisions. And I think that needs to be very, very clear, because if you don't have that, it's not even that the door is ajar, it's that the door is thrown open, and what rushes in but misinformation and disinformation and confusion.
So riffing spontaneously at the podium is probably not a good plan.
I would not recommend that. And
fair enough. So along those lines, how can we improve our state public health data collection and sharing to help us make better policy decisions that are in fact data-based and evidence-based?
Yes, and there, I mean, the one thing that we have gotten considerable influx of federal funding, particularly around data modernization. So part of what we've done already, we had this system called NEDS, which don't ask me what it stands for, but it's the system that we use and have used all along to gather in data about reportable infectious diseases, and then to spread data back out to our partners in our regions and in our city and county health departments. We were apparently about 7 generations behind in NEDS. It's a system that's owned and operated by the federal government. The funding enabled us to get the IT resources and the time to bring it up to date, and so now it is much more functional. So for example, prior to COVID, when there was a reportable disease like measles or say HIV or something like that, all that we needed in public health was the positive result. We didn't need negative results. We didn't need the results of people who'd been tested for hepatitis C and it was negative. We wanted to know who was positive. In the case of COVID, we absolutely needed both. We needed the numerator and the denominator everywhere, accurately and right away. So having that data modernized it will help, but we won't have to wait till the next pandemic in order for it to be of use. We will now, I think, be able to use this to much better effect in, Texas has a serious problem with congenital syphilis. Well, if we can get the data sooner and we can do the outreach and the disease investigation sooner, I'll bet you any money that we will actually be able to turn the curve, if you will, and improve that outcome. Likewise for things like HIV. The number of new HIV cases has remained pretty much constant now for years, but if we had better data and more manpower, and that's also part of what the feds have enabled us to do, we can do more of this. The difficulty with that is it's federal money and it has a limited lifetime, and when it goes away, the state of Texas will have to make a decision about what parts of that new capability and capacity it wants to keep. And I really think the mission of the Department of State Health Services and the mission of public health in Texas over the next couple of years is to be able to demonstrate to leadership that investment in this has value. Again, it has value because it makes for healthier communities, and healthier communities are more prosperous communities.
I think it's so important to continue to articulate the story that it is penny wise and pound foolish to dispose of these resources when we're not seeing smoke on the horizon we need to maintain that preparedness. We need to maintain that infrastructure so that we can respond in a way that limits illness and death. You mentioned congenital syphilis. It is a big problem, and how we can respond to something like congenital syphilis, which affects the arc of the baby's life if you don't do it right, is so important. So I'd like to shift a little bit to something that I like to term the parallel contagion, which is vaccine hesitancy, which has really become much more enhanced in the era of COVID-19 vaccinations, which seems to be bleeding over now into an enhanced hesitancy to routine vaccinations. I'd like to hear your thoughts about that and how the Department of State Health Services can respond to that.
Well, as far as the Department of State Health Services, we have a very professional communication department. We actually go out and do the kind of market research, if you will, that companies do when they're looking at products. In other words, focus groups. What messages resonate with people? What messages do people trust? And so to the degree that we can, we produce messages, public service announcements on that throughout lots of media, print media, television, radio, and of course a lot of stuff online to get that word out. I'm here to tell you, though, that public health cannot do it by itself. It just doesn't have the oomph. The oomph really comes from people's own trusted, a trusted voice. The most trusted voice is their own physician. And so if they have a conversation with their physician about it, I think that's the ideal thing. But hey, physicians are busy. People are busy. They're not all going to necessarily be able to go in there and sit down because, people have lots of questions about this. And so unless you rent a lecture hall, there's an idea for you, Dr. Turk, and invite all your patients in all at once and have a conversation, it's really difficult to have that in-depth thing.
We're not going to comment on how many people might show up in a lecture hall to hear me talk.
But the other part of it is, it's kind of an all-of-society thing. It is lamentable to me to look back and see how pervasive what I would call a lack of medical literacy is. And when I was in practice, my practice is in South Austin. A good percentage of my practice was Medicaid families. A good percentage of my practice, both parents were university professors. And I'm here to tell you that certain key aspects of what you might call medical literacy are lacking across the entire board. So any kind of assumptions you would make based on somebody's race or income or educational level, don't think that that's the only determinant about whether or not they have a really complete set of facts at hand to think about things like the virus. So early on, for example, again, the epidemiology, the science of how a respiratory virus spreads has been known for over 100 years. It's coughing, it's sneezing, it's sharing air with other people who have the infection, who may not even know they have the infection. Well, when you think about that, that means, wow, what are you going to do? Public settings, indoors, are going to be a place you really need to protect yourself. That could be where a lot of it things. Maybe going to the bar and listening to the band and standing, right next to each other and dancing real hard and singing. Maybe that's a high-risk situation to be in. But people resisted that. People didn't believe that. That wasn't you. And so you could give people facts, but unless they had enough of a background to have a paradigm in their head, the facts just became little factoids. They weren't part of a consistent way of reasoning and thinking about it. And so this increase in health literacy and increase in medical literacy, I think ought to be a society-wide project for a period of time, and hopefully will raise a new generation that does have the ability to reason more effectively about their health and about public health.
I think it is a real uphill battle, as you say, especially when there are forces aligned against the truth being a factual basis to what we discern as our reality, which is very challenging nowadays for all of us in practice. So what provisions have been made to the state's emergency response plan to expedite vaccinations in the case of another pandemic or an outbreak of a different novel virus?
We're in the process of doing what we call our after-action report, and the first one will really just deal with the first year of the pandemic, which will include some of the most crucial pieces of distributing the vaccine and that sort of thing. It's hard to do that. As you know, I mean, one of the amazing things was who got the brunt of being the vaccinators early on? Hospitals. Now, I think for a lot of people that was, oh, that's natural, hospitals, the shots, vaccinations. No, that's not what hospitals do. No. They do not do mass vaccinations. And yet, because we wanted to have their staff be the people who had the priority and got vaccinated, it was in fact natural to give them vaccine and for them to begin initiating vaccination projects. God bless them. They opened that up to the community, and then from there, as vaccine supplies increased, other more traditional accesses came up. Things like the Texas Department of Emergency Management would have mass drive-through vaccinations, again, once the supply got there and the demand was still really high. So I think we learned how to operationalize the things that we needed to do in the context of what was there. And that's about as far, I think, as planning can go, is to have that institutional memory and to understand that the next time may have a unique set of facts, and you're going to have to adapt your operations to those facts.
I think it's really important that hospitals learn how to do this, and there are other parts of our public infrastructure that we're able to stand up processes to serve the public in the way they did, and hopefully that is sort of muscle memory that will be built in for the future, not if, but when we have another event such as this. I'm going to stick with infectious diseases for a little bit longer, and then we'll shift over to something that's not infectious diseases. But you mentioned HIV transmission. Another important disease which is relevant to our public health is hepatitis C transmission. Can you give us some commentary about that in our state?
I don't have data on that right now. As you know, I mean, hepatitis C presents a kind of a unique challenge in the sense that it is relatively easily transmitted by certain types of contact, especially. But now there are cures available for it, and so the challenge will be to get those medications to get people tested and to get them on those therapies. But I'm sorry, I just didn't come prepared with data based on it.
So as promised, shifting away from infectious diseases, let's talk about tobacco prevention and control here in Texas. What does DSHS have planned in those areas?
We will continue the sorts of kind of public service announcement campaigns. We will continue our quit line, which I think the quit line is one of the most valuable and effective tools that we have. Why?
Can you comment where that came from, by the way, the quit line?
Tell me.
The quit line is something that is available in every state and is funded by the Omnibus Tobacco Company settlement that occurred back in the late 90s. And so when I have a family in my practice or a routine in my practice, that's one of the resources that I give them is 1-800-QUIT-NOW.
Right, and so tobacco is a particularly tough nut to crack. You know, now I think maybe more than before, or at least there's an acknowledgement that nicotine is an addictive substance. And people are taking that part of it very seriously. So anything that delivers nicotine to people, you know, the question is, okay, does vaping, can you use it to quit? Yeah, you probably can. But could you end up being hooked on nicotine through it? Yes, you might, and maybe you would smoke tobacco as well. And again, the other thing that I think is very worth noting about tobacco is that everybody knows it's bad for you, even the people who smoke. And so it's one of these examples of where knowledge isn't enough to have people take action. But that's where the quit line comes in, as far as I'm concerned. It's especially valuable because the person making the call wants to quit. That's why they called. So they've made that decision. And the more we can do to support that decision, the better. But I can remember when I was growing up, smoking was normative. Okay? Your doctor might tell you to start smoking so you could lose weight or calm down or whatever. The doctor might smoke themselves. People smoked everywhere. It was normative.
In the hospital.
Right, in the hospital. How did that change? It didn't change just because of the Surgeon General's warning, which was a landmark, don't get me wrong. But it became something that all of society began to recognize as very unhealthy, very destructive. And so the message came from everywhere about it. I think if we're going to go in the next steps, what we should be doing is preventing people from getting hooked on nicotine, and we should also be providing them with assets like the quit line. But it, again, to me, would be best as another all-of-society kind of message push to say, yeah, we've decreased smoking rates to about, I think it's about 18% of adults in Texas. That's not low enough.
And these are not words in your mouth, but they'll come out of mine. I think the other important policy determination that should be undertaken is that we should tax vaping products and e-cigarette products in the same way that we're taxing traditional tobacco products. I think that's an important policy consideration as well. So I have two more questions for you before we conclude. And the next question is not from a Monty Python skit. What about monkeypox in Texas?
Monkeypox it should be taken very, very seriously. And the thing to remember is the first thing that CDC put out as a message. Monkeypox is not a sexually transmitted disease. Monkeypox can be transmitted during sexual activity, but monkeypox can be transmitted during any close, what they call prolonged, I'm not sure I know what that means exactly. I think they say 15 minutes. That seems extremely arbitrary to me. Skin-to-skin contact. The other part of monkeypox that is, gives me great concern is that it can be transmitted relatively efficiently through inanimate objects, what doctors call fomites. So that's in contrast to, say, COVID-19. There was a lot of concern early on that why would you take the bag from the guy who delivered the DoorDash because it's got COVID on it. Well, it turns out that the COVID virus really wasn't going to be transmitted that way.
It's not that hardy.
It's just not that hardy. That's different from monkeypox, so it's very clear that surfaces can be contaminated with viable monkeypox from a person who has an active rash and has the secretions, and particularly things like bedding. So that really increases the risk in households for non-sexual partners. And there's been some cases where household members who are not sexual partners did in fact contract monkeypox. So the good news about monkeypox is, so far in the U.S., no fatalities. There have been some hospitalizations. The reports I've heard and read about, it was due to pain control. It can be a very painful rash. But we really need to get it under control because right now, even though the vast majority of transmission is taking place in the men who have sex with men community, when there's no doubt that there is a risk that it will spread beyond that community as well.
So you've let it be known that the sun is setting on your career with as our Commissioner of Health. What would keep you up at night as the Commissioner of Health? What should keep the next Commissioner of Health up at night with worrying about things for the future? What is the thing that one might be most concerned about as we go forward, as we emerge from the worst of the pandemic?
Well, blind sight, but blind sight in the terms of policy with regard to public health in the state of Texas. And once you learn very quickly, when you go work for the state, the budget is policy. So, and I don't mean to say that lightly, by the way. Politics is not a four-letter word. Politics is the way we get things done. Politics is the only way that we can have compromise in our society and peace and make progress. So I have ultimate respect for that system. And within that, there is a great sense of the fact that the government has this money in the form of taxes and fees and things like that that come from the people, and that their obligation is to employ that funding in the way that best benefits the public, and that the public sees the value of doing that. And so the thing I think going forward is to be able to demonstrate to our leadership and to the public the genuine value, and I mean that in dollars and cents, the genuine value that public health brings to the state.
Amen. With that, I'm going to bring our talk to a close, but I'd like to express my personal appreciation to Dr. Hellerstedt. It's my opinion that people who devote their lives and their talents and their energies to keeping us healthy and safe are heroes, and I think this is one of our heroes right here. Thank you so much.
Thank you, Dr. Turk.
Thank you so much for joining us, and be on the lookout for the next announcement in our Distinguished Speaker Series. Thank you for attending.